Okay, so good afternoon, everyone. Thank you very much to all of you for turning up for the third lecture of our Year 3 series. So in today's lecture, Professor Khong Chu will be covering the topic of burns, soft tissue infections, and ulcers. And today I'll also be joined by our President Cleo and Amar as well in co-hosting this afternoon's session, which hopefully will serve some of you well in your revision for the upcoming written paper. Allow me to take a minute to introduce Professor Chu. So Professor Chu is our esteemed international tutor, and he has contributed much to our society as one of the earliest members. And he's a plastic surgery consultant from Singapore. It's really late at night in Singapore right now. So thank you very much to Professor Chu for being generous with your time tonight. Professor Chu happens to manage the largest burns unit in Southeast Asia at the Singapore General Hospital. And with his extensive expertise, he has also helped us greatly with our inaugural Evening in Microsurgery and Microsurgical Skills workshops, both of which have been very well received by our delegates. So without further ado, I will now pass the time on to Professor Chu, who will deliver his lecture.
Thank you very much, Kelvin. This is my first time doing this over Zoom, so please bear with me. And welcome to everyone. And I understand that this is going to be a lecture, but I would like to have this as more of an interactive session, since everyone is free to contribute. And if there's any question, please feel free to stop me. So today's lecture, we are going to maybe cover very, very superficially, as much as we can, the various topics. And the three topics that I've been given is infections of the soft tissue, ulcers, as well as burn injuries. So as you might know, any of these topics can be a whole textbook by itself. So my plan is just to give you an overview. So I'll start with maybe an interactive slide to gauge sort of what kind of level or what kind of participation you want me to do. So let's start with the first one. Can anyone tell me what they see on this slide? Calvin, maybe we'll start with you.
Okay, so I see some form of I will describe it.
Maybe I'll just give a bit of a background. So this 6-year-old boy been having this lesion for the last 6 months. He's 6 years old. He's got a history of eczema, but this started as like maybe a small pimple, but has progressed over the last 2 weeks to these what appears to be multiple reddish plaque-like lesions with what you can see as dried crusts. And he's got no other significant medical history. He comes in with these painful lesions. How would you describe them to begin?
I see. So as you mentioned, it's scaly. It looks scaly. It's also erythematous as well. So it looks like some form of a rash. And as you say, it's possibly associated with his eczema, his history of eczema as well. So probably some form of a dermatitis, maybe seborrheic dermatitis, yeah.
Okay, so basically, when confronted with a clinical photo like this, you would want to process and maybe keep talking. So what you might want to say is this photo of a 6-year-old with what appears to be multiple lesions around the face. So you can see that there's crusting. Yes, there is what appears to be maybe pustules. And what does crusting mean to you? It means there is some sort of discharge, yes?
Yeah.
And some redness. So at the back of your mind, you would want to know whether or not this is infective or autoimmune or vasculitic or you know. So I would say that the approach is correct, but the reason why I want to show you is I just want to show you that it's just so difficult to just do a spot diagnosis when confronted with just a photo like this. Yeah, and let's move on to the second one. So let's say this one. This is a bit better in the sense that it gives you a context, right? So you know the location of the lesions, you know that the rough age of the patient, and you would also describe that there's multiple lesions. Where would you say this location is?
I'll probably say it's more of the scalp.
Yeah, so it's the scalp. It's more specifically at the hair-bearing area of the scalp, right? So that will give you a bit more clue as to what is the pathology. Since we all know that this is a infection lecture, so would you like to hazard a guess as to what it is?
I'm sorry, to the audience, right? If you have any questions, you might want to either if it's a question to Mr. Chu, it'll be good to share the question with everyone. Or if you want, if you
I can see the question here, yes.
Yes, there's someone who said, was the previous yellow crusting impetigo? The previous case.
Yep. So the answer would be yes. So, but I'll come to that in a while. And I just want to start off with a few lectures so that I know what you guys are at, what kind of level you guys are at. Yeah. So this case would be a folliculitis. Yeah. And the reason why I want to show you all this is that infections of the skin has got a whole range, you know, from impetigo to folliculitis to carbuncle to abscesses. And of course, at the end of the extreme, you get necrotizing fasciitis, soft tissue infections. So to start off the lecture, I want to tell you guys that this is a very big topic. Yeah, and of course, for you, perhaps you might want to just concentrate on erysipelas and cellulitis. Yeah, but do bear in mind that there are many more, and it might be good for me to just go for an overview of what are the various soft tissue infections. Yeah, and like someone correctly pointed out, HR. Yeah, so this is impetigo. So impetigo basically is a superficial infection of the skin, and it can have three different types. A bullous one, or rather when you see bubbles on the skin, a crusting one where they just, you know, because of scratching or maybe because of some the nature of the disease, it becomes oozy, and crusting implies that there's dried proteinaceous liquid, dried exudates. And of course, you can be ulcerative as well. And ulcerative is usually what we term as ecthyma. And most of the time, the pathogen, as with most soft tissue infections, would be commensals of the skin. And these commensals are commonly staphylococci and streptococci. So any bullae that ruptures eventually will form yellow or golden crust, as you can see in this case. So ecthyma is basically a deeper form of impetigo, and the definition is that it is an invasive form, and usual pathogen is streptococcus. Because of most of the time, it's because of the host's immunocompromised state, and these can, of course, for every of the conditions that we have described, these can be a progression. So doesn't mean that just because you have impetigo, you will not get folliculitis, for example. All these can cross-infect because these are pathogenic bacteria. And like we mentioned earlier, folliculitis is another one. So it's basically bacterial infection of hair follicles, even in areas that are not readily bearing hair. We can get folliculitis, and again, caused by Staphylococcus, occasionally Pseudomonas, and these are usually related sometimes to inadequate treatment of water, and sometimes we call this a bathtub syndrome. And how about furuncles and carbuncles? Basically, once folliculitis worsen, it leads to abscess formation, and an abscess of one folliculitis, we can call it furuncle. But when multiple furuncles or multiple subcutaneous abscesses cluster together, they form what we call carbuncles, which are basically separately connected abscesses of what could have started from a folliculitis. Sometimes carbuncles can be deep as well. In this case, in the photo here, you can see that there are multiple pointing lesions and there are open holes. And the reason why carbuncles tend to be worse is the fact that they are septated collections, and sometimes these infections can be fairly deep right into the subcutaneous tissue as well. And carbuncles are commonly seen when there's host immunity issues such as diabetes. We see them a lot in an Asian context on the backs, for example, where Asian skin tends to be a bit thicker. And in the country where humidity is very high, we do see a lot more of these. So we move on to, I won't go through all the rarer conditions of soft tissue infections, but it seems to me that cellulitis and erysipelas are part of your syllabus. So we're going to go into this topic of cellulitis and erysipelas in greater detail. And in this slide, this is a summary basically of what is cellulitis and erysipelas. Most people would say that cellulitis and erysipelas are similar but separate conditions, but increasingly people are recognizing that these are two variants of the same issue. Basically, they are soft tissue infections involving, in this case, as you can see, cellulitis is a deeper involvement and erysipelas is a more superficial involvement. If you want to be discreet about it, erysipelas has traditionally been defined as superficial lymphatic involvement, whereas cellulitis involves deeper structures and they don't show superficial lymphatic involvement so readily. But bear in mind, both conditions can occur even in the same individual within the same region. Now, erysipelas, being a more superficial infection, shows more readily and tends to have a more acute onset. They can have systemic symptoms of pain, fever, and most of the time it is non-purulent. It involves most of the time the upper dermis area, whereas cellulitis usually would involve deeper subcutaneous tissue. It can originate from the deep end and eventually manifest as erysipelas. It tends to be indolent because the signs are less common. So most of the time, patients can even feel the pain before they see the condition. And if you read the dermatology textbooks, erysipelas tend to focus on separate, these discrete entities, especially on the face. And on the face, you can see these are superficial cellulitis with what appears to be very well-defined margins around the cheek, the nasal bridge, and crossing both sides. And it appears to look like a butterfly lesion. And these tend to be shiny, raised, indurated, and most of the time tender. And it looks plaque-like. And in the face, erysipelas tend to be related to group A beta hemolytic strep, while in the lower limb, it's usually other types of streptococcal infections. So since we are on this topic, and if you want to define it carefully, it's usually differentiated from cellulitis by having sharply defined margins, as we mentioned. And just a additional tip is also known formally as St. Anthony's fire, after the very intense rash that you can see. So to summarize, both are infections of the skin and subcutaneous tissue. They are both widely regarded as variants of the same condition. They often coexist within an affected area. There are, of course, signs of fever, chill, and malaise. And the commonest pathogen are these two. Whereas cellulitis, to differentiate with erysipelas, it affects deeper structures. The margins are usually less identifiable, and they generally develop in a more indolent onset over a few days. So I would like to add as well that they are more difficult to identify in darker skinned individuals. So what are the risk factors that we know of? So basically, both conditions can start off with a minor trauma, like insect bites, or walking barefoot, or handling raw food, fish, get pricked by stonefish, for example. And they are especially common in people who have inflammatory skin conditions like psoriasis, eczema. And for erysipelas, especially, that usually people with impaired lymphatic drainage problems, for example, where lymph nodes from the axilla has been cleared from breast cancers and from pelvic cancers where they affect drainage of the lower limb lymphatics. Immunosuppressed individuals, of course, they tend to get more problems, and more specifically for erysipelas, obesity tends to be a risk factor as well. So it usually starts with a minor trauma or skin break. Lymphatic impairment is found up to 1/3 of patients with erysipelas. So pre-existing lymphedema is a risk factor. So what are the bacterial sources? These are by far the main source. Group A strep for facial infections, and for lower limbs, non-group A strep. For facial cellulitis and erysipelas, up to 1/3 of patients do express recent streptococcal pharyngitis. And for rarer pathogens, we have seen Klebsiella, Haemophilus, especially for neonates, Yersinia, where there is exposure to animals or cats. And it is thought that streptococcal toxin tends to cause a much more rapid and much more aggressive response for these cases. And in terms of epidemiology, we see more commonly among European countries. Since the mid-20th century, there's been a decline, especially after the advent of penicillin. Unfortunately, since the 1980s, there's been some gradual resurgence due to diabetes and AIDS. And as far as I can tell, the only incident that was measured was about 2.5 persons per 1,000. And out of these, 16% tends to have recurrences due to the factors that we've discussed earlier. For the age group, peak incidence occurs around 60 to 80 years, especially the facial erysipelas, especially in immunocompromised individuals, patients with impaired lymphatic drainage. They tend to be more common in females, although in earlier ages, they are more common among boys. And as we have discussed, usually they are preceded by symptoms such as fever, chills, malaise, and often can sometimes occur even 24 hours before onset of skin signs. So when you see patients in the clinic, you should ask them when the symptom starts. And this can be quite telling in terms of diagnosis of these two skin conditions. They sometimes do lead to itchiness, burning, as well as tenderness. Now, as we all know, the cardinal signs of infections are pretty common. Redness, pain comes a bit later, swelling and warmth. But in situations where they develop more severe symptoms, you might see that they are breathless. In cases where they become gradually less and less conscious, they have a high fever, you will have to think of bacterial infection of the bloodstream, septicemia. In cases where you find that the redness progresses rapidly, where pain becomes much higher than just the inflammation alone, then you would have to think about necrotizing fasciitis. In this case, typically, erysipelas and cellulitis affects mostly on the lower limbs. Facial erysipelas is less common, although it does involve both cheeks and the nasal bridge classically. And as we mentioned before, 1/3 of these patients do have a history of previous sore throat, and these are usually the pathogen responsible is Strep pyogenes. So what are the investigations that we take? As you can see from the photos, we tend to be able to diagnose them. Generally, no workup is required for simple uncomplicated cases, such as where the area of involvement is small and limited, where there's minimal pain, patients are able to walk around without any problems. If there's absence of systemic signs, no fever, and the patient has got no other risk factors, they're young, they're healthy, we would do laboratory investigations when we see the more serious signs, as we mentioned before. So ESRs, C-reactive proteins, neutrophil counts, these are important just to exclude this from, for example, autoimmune conditions. Where there are weepy or purulent areas on the skin, these areas can be swabbed for microscopy. Even if there is an existing erysipelas, secondary bacterial infection can occur, and these tend to lead to more severe infections. And in patients with problems with illness, severe illness, comorbidities, or immunocompromised states, we would advise blood cultures. And it goes without saying that antibiotic regimens are the most effective, and frequently, if started early, it is effective in more than 90% of patients. The first line of treatment would usually be the penicillin groups. The cephalosporins can also be used, and these tend to be more common among more advanced countries because you tend to get more of the bacterial-resistant bugs where amoxicillin might not work. For people who are allergic to penicillin, we can use clindamycin, or even macrolides such as Clasid and azithromycin. Now, it is important to warn patients to return for review, to watch for developments of bullae. Bullae are basically pus fluid collection underneath the skin, much like first degree, second degree burns. If there are purulent discharge or abscesses, these needs to be drained surgically. Most of the time, cellulitis and erysipelas do not present with purulence, and these are usually related to streptococcus, and treatment is pretty simple and straightforward with antibiotics, with good personal hygiene, and maybe a bit of dressing. For severe cellulitis in an immunocompromised host, a broad spectrum antibiotics might be necessary. Anyone know what is an example of a broad spectrum antibiotics? Have you guys had any experience in terms of the pharmacology? So I can't hear you. I think you're muted.
So probably like comoxiclav.
Yeah, okay. So amoxicillin and clavulanate, right? So that's an example of good broad spectrum antibiotics. But in someone with say severe uncontrolled diabetes, they are having fever, I would then admit them for intravenous antibiotics. Yeah.
Someone said take tazocin and aminoglycosides.
Yeah, so tazocin is a much more broader spectrum antibiotics, and it's an intravenous antibiotic. So we don't generally give unless they are inpatient. Yeah, but tazocin is another one that I would sometimes use, especially if the fever or the systemic symptoms do not resolve within 24-48 hours. Does it make sense?
Professor
Okay.
Chu, there's a question on
Mhm.
the oral antibiotic regimen for
Mhm.
cellulitis and erysipelas. So someone was asking if flucloxacillin would be given, oral flucloxacillin
Yes.
given for Staph aureus, like to target
It
Staph
really
aureus.
depends. It really depends on the local antibiogram. And most of the time, the infectious disease specialist would tell us, what is the community prevalence of, say, for example, MRSA, and in that case, we go straight to a more second line, like what you correctly mentioned, or even cephalosporins. In Singapore, we don't carry flucloxacillin. Some of the veterinarians, they do have that in my hospital. Especially, they usually go straight to the third generation cephalosporins like cefalexin. Yeah. Does that answer your question? Okay. So let's move on. Anything so far? Anyone want to ask anything? No? Okay. So for specific conditions where there is a history, for example, if someone has told you that they went to the sea, or they were exposed in brackish water, suffered a fish bite or a lobster bite, for example, then you want to think about coverage of aquatic bacteria. Anyone want to hazard a guess about what kind of aquatic bacteria we frequently encounter for skin infections? Yeah, okay, so maybe it's a bit too advanced. So usually we see Vibrio. Yeah, Vibrio, usually Vulfinicus, I think. But generally, Vibrio bacteria, we need to start doxycycline or some of the fluoroquinolones. And if without other, so for example, if you started doxycycline and they don't get better, you also need to consider atypical mycobacterial infections, yeah, so such as mycobacterial abscesses, which are commonly present in still water. So for example, in rivers, in tropical climates, you know. So atypical mycobacterial infections tend to be much more indolent. They don't present with very bad redness and erysipelas. And classically, what we find is the pus is sometimes grayish or bluish in nature. For human bites and animal bites, they have their own sets of bacteria. So like in humans, we frequently see Eikenella species. In cats, we see Yersinia. So we will start broad spectrum. In this case, I would generally start amoxiclav, like you've mentioned, Kelvin. So there is also an entity called periorbital involvement, and these are usually in young individuals, neonates. You know, Haemophilus influenza is one of the most common bacteria that we see, and if not treated early, these can lead to very severe symptoms and even things like cavernous sinus thrombosis. So these are fairly rare. So, and when you see that in young individuals, you need to have danger flags. So as to the treatment, generally speaking, if it's limited, you know, we usually advise elevation, icing, immobilization, and if there's any discharge or wounds, then we would advise antiseptic dressing to prevent secondary bacterial infections. Okay, so that sort of covers most of the things that we need to know at your level for erysipelas and cellulitis. I just want to separate them from the more discrete infections such as folliculitis and impetigo. The impetigo and folliculitis tend to be much more self-limiting, but they can develop eventually into cellulitis and impetigo. Yeah. Shall we move on? Is this too fast, too slow? Okay. So necrotizing fasciitis again is a very, very big topic. We are switching gear into something that is potentially much more life-threatening, much more important to know if you're practicing in a tertiary unit. So maybe Cleo, would you like to describe what you see on this photo? Or whoever wants to volunteer, please. Mr. Rai.
Mr. Rai.
Oh, sorry. Did I get a name wrong? Amar, no. Sorry. I'm so sorry.
Yeah, that's fine. I don't know, I think I can see some bruising there for sure. I mean, you see from the dark colour skin, and there's blistering around the ankle region. There's also a lot of edema present too, as you can see from the swollen ankle to the leg. That's all I can see for now.
Okay, so for me, I would generally do a zoom in technique. So what I would say is that this is a photo showing the right leg of an individual. You can then say that it shows the photo from the foot to the lower thigh. You can say that, you know, in an exam situation, you would do that. Then you zoom into the pathology. So the first couple of sentences allows you to have a preamble while you think about how to describe it. Yeah. So then zooming in, you can see that the pathology seems to be localized to the foot dorsum, the ankle, as well as the calf, all the way up to the upper thigh. There is a very irregular discoloration of the skin, and it is heterogeneous in appearance, with some areas being lighter than others. You can also add that there appears to be blisters forming, which tend to be, some of them appear to be hemorrhagic. Yeah, the skin itself looks very shiny, looks very tight. The leg appears to be immobilized, or patient appears to be lying down on a bed. So that's how I would first describe. Yeah. So if the examiner asks you, okay, what would you do? Then you can say, okay, I would like to proceed to examine, and palpate. So first to feel the pulses. Secondly, to examine the blister in greater detail. I would like to look at the other side of the foot, as well as the contralateral limb. Yeah. So this is how you would describe. So if they want you to commit to what you see, you can say that there appears to be skin changes indicative of some sort of infection or ischemia. Yeah, does that make sense? And
thank you.
I would say that there's also associated cellulitis, as can be seen proximal to the demarcated areas of the skin. Yeah, so that's usually how a surgical candidate would approach exam when given a clinical photo. Yeah. Okay, so let's move on, and we know that this basically is necrotizing fasciitis, and by the time you see this kind of appearance, what do you think the patient would be like, Calvin?
Was it Calvin or me?
I think,
Okay, yeah, sure, carry
I
on.
think
What do you think the patient's condition would be like?
he'll probably be systemically very unwell. So
Yes, exactly. So by the time you see this, basically this is a late stage necrotizing fasciitis, yeah, and the limb tend not to survive. Why is that the case?
Is it where the circulation shuts down? So on the extremities, or?
Yes, circulation shuts down, but in a very specific manner. Yeah, it doesn't mean that the femoral artery stops flowing, or the posterior tibial or the anterior tibial artery stops flowing. Yeah, basically, it's the vessels that supply the skin and gets affected, and they get thrombosis, very extensive thrombosis, and you might start with a few patches of dark looking skin, and then they coalesce into this kind of picture. Yeah, so the ironically the pulses, the pulses around the ankle or the dorsalis pedis might still be present, because usually in fever they get hypertensive, BP shoots up. But in this kind of situation, generally they will be very septic, they would appear very toxic, and they would be having swinging fevers, and they will have a lot of pain, so they won't be walking around, definitely. Okay, so I just want to highlight to you, because frequent times by the time patients come in like this, then you would have missed the diagnosis. At this point, the chance of patient dying would be very, very high. Okay, so then we move back a couple of steps, and we would let's talk about how to define necrotizing fasciitis. So basically, necrotizing fasciitis is a very rapidly progressive, the keyword being rapidly progressive, inflammatory infection of the fascia plane, and this can cause secondary necrosis of the subcutaneous tissue and skin, which we have seen earlier. It tends to be rapidly progressive along this specific fascia plane. Now, can anyone hazard or guess as to why they only progress along fascial planes? Why not muscle? Why not blood vessel? Cleo? So we know that fascial planes tend to be the planes where muscle and skin or subcutaneous tissue plane glide, yeah? And so in these planes, usually the vascularity tends to be much less. And that allows bacteria to survive and, out of the body's immunity. I mean the white blood cell in the circulation. So in areas where they are less vascularized, they tend to have more bacteria. And there's this particular entity we call Fournier's gangrene, which basically is also necrotizing fasciitis, which involves perineal structures, the scrotum, the labia, and so on and so forth. And these tend to be very specific, and in at least in our context in Singapore, we do tend to see quite a number of Fournier's gangrene. So what are the other causes that can lead to this kind of deep soft tissue infection? So basically any surgical procedures where there's intraperitoneal breach, when you do any kind of laparoscopic or bowel surgery, it can start, of course, most of the time, it can start as a minor injury, skin break, insect bite, and it is very common, especially where there is any form of local ischemia and hypoxia like diabetes, patients who are undergoing cancer treatment, immunocompromised hosts. And causative bacteria tends to be aerobic, anaerobic, or even mixed. And these are very specific bacterial types. And generally, we say that there are three important types that at your level you might want to know. So there are three types. The first one is the commonest, being a polymicrobial or mixed flora type. Type 2, the more common one, is a group A streptococci infection. And group 3, these are what we usually see on textbooks, where there is a presence of gas underneath the subcutaneous tissue. And these tend to be related to Clostridium species where they are commonly found in the ground. And of course, the variation to type 1 would be the Vibrio species that we have spoken about. They tend to be found in a saltwater situation in a humid climate, especially. And because of the rapid and destructive cause of this infection, this is the process is thought to be more than just one bacteria. Sometimes the other bacteria provides some kind of synergy, and we'll go into a bit more detail. And the proliferation in the soft tissue with local hypoxia usually results in combination of these gram-positive, gram-negative, as well as aerobic and anaerobic bacteria. So what are the pathophysiology? So if you, I don't want to go into too much detail, but suffice it to say there are important bacterial factors, and these are usually secreted by specific bacteria. For example, surface protein expression in streptococci bacteria tends to improve the adhesion of tissues to the muscle, and that prevents phagocytosis from white blood cells. Streptococcal exotoxins and streptococcal superantigens you would have read about, you might have read about. They do release large amounts of, they induce the body to release large amounts of cytokines, and these tend to cause the hypotension and the sepsis that we see. And sometimes even specific toxins, for example, they tend to bind to muscle, and this can lead to this very rare condition called necrotizing myositis, which is an extension of necrotizing fasciitis. Now, epidemiology-wise, there's an increasing incidence that we are seeing because of the more and more incidences of patients with very immunocompromised states, from diabetes, organ transplantation, for example. Ironically, they tend to affect people who are younger, and they rarely occur in children, but when it does, it tends to be quite fatal. Male to female ratio tends to be 2 to 1. So males are more commonly affected. Comorbidities can be found in majority of these necrotizing soft tissue infections. So diabetes, apologies for the typo, account for up to 40% of individuals, and in Fournier's gangrene, up to 80% of our patients we see, they suffer from diabetes. Alcoholism and liver cirrhosis has been said to be parts of the etiology and risk factor. So as we have mentioned before, these are the various risk factors. And there's also this possible link with NSAID use during zoster infections. This is a very specific link which has not been proven nor explained. So in Imperial College specifically, I found this paper, and this is a good review paper of the incidences of necrotizing fasciitis in London, and they tend to show that patients do present about two days earlier, 2 days from the onset of symptom. My apologies, but it can range from anytime from 1 day to up to 7 days. Early symptoms are often very, very difficult to recognize, and hence we need to have a very low threshold for diagnosis. Patients, unfortunately, can look deceptively well initially, and bear in mind these are people who are in their middle ages. Unfortunately, they very rapidly become toxic and unwell within hours or days. Intense pain and tenderness often occurs before even any of the systemic symptoms start. And over time, pain can progress very rapidly proximally and into the areas that is more proximal. And the initial areas that had pain might in fact develop anesthesia, and I'll go into that in a bit more detail. The initial lesion is often trivial, so a lot of times they tend to be idiopathic, or they do not know what was the initial, they forget what was the initial injury. They do develop a lot of erythema initially that is similar to cellulitis, so it can confuse the picture, and a lot of times some of these individuals get treated with antibiotic and sent home. So it's important to warn your patient that if it doesn't get better within a few days of antibiotic, they need to come back. And so the skin near the initial area tends to develop after a while this purple or dusky discoloration, as we've seen from the first photo. And very later on, gangrenous patches may appear and they coalesce into one big patch. So other signs that we can see more proximally to the lesion would be edema, followed by skin vesicles as the disease progresses. Initially, it can be clear, but once there is bleeding and capillary rupture, they tend to become hemorrhagic. In certain situations, you do feel crepitus above the areas where they are painful. So these are subcutaneous gases, which can present in up to half of patients. But my experience is they tend to be quite rare, except for Clostridium cases, and they can be detectable on X-ray. And of course, for Fournier's gangrene, you will see a lot of swelling, especially where the scrotum is concerned because of extensive edema. So it has to be emphasized that diagnosis of necrotizing fasciitis has to be made clinically because it is a surgical emergency. And most of the time, it can only be confirmed during surgery. So we tend to rush in if the suspicion is there. And more importantly, what you see is the more classically described as a redness and pain that is out of proportion to the physical appearance. So the reason is because it takes a few days for skin necrosis to present itself. So during surgery, we might see that there is gray necrotic tissue. There's lack of skin bleeding. So lack of skin bleeding is an important sign because the skin would stop bleeding. The vascularity of the skin is affected initially, and about 2 or 3 days later, then they present with these necrotic appearances. So there's lack of resistance on blunt dissection in the fascial planes, and this foul, water pus that we tend to see. So let's go into a bit more detail. So investigations, as I mentioned before, there are various investigations available, but the diagnosis again is clinical. Lab tests has not been proven to be diagnostic, but it's helpful to assess how stable the patient is, in terms of the hemodynamic status, whether the sepsis has affected their kidneys, for example. And in some units, they will say that white cell counts they tend to be very much highly elevated. Urea level can be high because of dehydration, reduced sodium level, arterial blood gas, and blood and tissue culture. These tests tends to be late by the time they show abnormalities. And of course, there are newer diagnostic techniques that, such as rapid PCR test kits that test for exotoxin genes produced by specific bacteria. So for imaging, MRI, again, it can show signs such as fat stranding, such as a loss of perfusion in the contrast scan, and necrosis. And it is also helpful to show the extent of spread in a, for example, in a limb, you know, and it guides how much the surgeon needs to excise and debride. And of course, it can sometimes, even with ultrasound, you can pick up subcutaneous fluid along the fascial planes. But it needs to be emphasized that necrotizing fasciitis is a surgical emergency. Lab test imaging should not delay surgical intervention. So if anyone asks you, would you wait for the test? The answer is no, you need to go in clinically. So there have been, specifically to necrotizing fasciitis, because of the difficulty in diagnosing the condition, there's this thing called the laboratory risk indicator for necrotizing fasciitis scoring system. This was devised to stratify the likelihood of infection based on these tests that we can see listed here. And the score is based on how high these tests are done. So from a study that was done, it apparently, if it's score of 5 or under, these are low risk, and if it's 8 and above, up to 75% of these individuals would go on to develop necrotizing fasciitis. So it gives a positive predictive value of 95%. According to the literature, but there have been variations in how much false positives and false negatives these are. So moving on, when we see these patients and they go for surgery, it is important that we confirm the diagnosis surgically, by not just by appearance but also by taking cultures and histology. So the specimen should be taken from the periphery of the infection, not actually the necrotic regions like the dark patches, because these may no longer harbor viable tissue or bacteria. So interestingly, on histology, these tend to be quite pathognomonic. We tend to see very classically occluded blood vessels. These are the blood vessels that puncture through the fascia where the bacteria spreads. So they get occluded because of all these toxins that are developing along the planes. And they can have very dense infiltration of neutrophils, subcutaneous fat necrosis, as well as a lot of inflammation of the blood vessels. So this is going to go into a bit more detail in terms of the treatment. So, but suffice it to say, the key is to have very swift, aggressive management, and these have been shown to produce the best outcomes. Rapid progression of the disease causes thrombosis of blood vessels, and this can cause ischemia of the skin and nerves, and that's why paresthesia and anesthesia of the distal parts of the limb would then develop. By the time they have nerve injury, that's basically a late sign. And even later, when there's progression into muscle, they tend to lead to myositis and myonecrosis. We tend to see these kind of patients, by the time they see us, they would be in the ICU. They tend to have to go for amputation, and frequently I've seen in my career at least 3 cases where they need to do a hindquarter amputation, where the limb is removed from the acetabulum down. And the answer to treatment of necrotizing fasciitis is always emergency surgical intervention, as well as hemodynamic resuscitation. As soon as a patient is fit for surgery, they are rushed to the operating theatre. After surgery, they are usually admitted to the surgical intensive unit because they are hemodynamically unstable. The surgeon should actually take up aggressive debridement, and these have to proceed above the affected fascial planes, because as I mentioned, these progress rapidly, and you need to go above the plane of infection just to clean up everything. Repeat debridement usually necessary. Frequent times we reload in about 2 to 3 days if they are stable enough. And sometimes when irreversible necrosis and limb gangrene develops, or when the patient has overwhelming toxicity, we then speak to the patient's relatives to tell them this is a life over limb situation, and amputation is usually inevitable to save lives. So antibiotic therapy has to be started prophylactically because you can't wait for the bacteriology to return. Penicillin and aminoglycosides first line, we usually cover with clindamycin as well, and these tend to be designed to cover Streptococcus and Staphylococcus, which are the two most common ones. Gram-negative bacilli and anaerobes are the synergistic bacteria that tend to grow within the wound. Now, there have been talks about hyperbaric oxygen treatment. These tend to reduce the progression of the disease, but it's only an adjunctive treatment, and we only use it where available, and this does not supersede surgery in any way. You cannot transfer the patient to a hyperbaric oxygen chamber while the patient is unwell and acutely sick. So what do we find when we open up? So basically, destruction of fascia causes massive undermining of subcutaneous tissue. Basically, the skin fat layer separates from the fascial layer and the muscle underlying it. With a gloved finger, frequently you can pass through the layers very, very easily. And in cases such as in certain cases, fascia may just appear very unhealthy, but the tissue necrosis produces this very classical appearance of grayish, turbid water, which has been described as dishwater fluid. These are basically liquefaction of the fascia. So what are the complications? Complications happen because the fascial planes spread because of bacterial enzymes and toxins. These can cause a lot of vascular occlusion, as we have described, causes ischemia and tissue necrosis. Superficial nerves are damaged, and these can have long-term or permanent limb numbness, and muscle and paralysis, because even the motor nerves can get involved. So other common complications: renal failure, septic shock. Frequent times they get a lot of scarring problems, amputation, as well as even toxic shock syndrome. So the prognosis we see, it has been reported mortality rates to be as low as 20 to as high as 80%. And most of the time, mortality goes down very, very rapidly if not treated early. And specifically for the streptococcal variants of the necrotizing fasciitis, they tend to have a much poorer prognosis. And there have been independent predictors. These are things like liver cirrhosis, hemorrhagic bullae formation, chronic renal failure, age, of course, more advanced age, as well as location. So upper limb necrotizing fasciitis are usually associated with higher mortality rates. Okay, so I think I will stop here, but this is a good summary slide which I found, and this basically shows the location of these conditions that we have discussed so far. So in the skin and subcutaneous tissue infection, at the most superficial level, you have impetigo. Deeper in, you get folliculitis. Erysipelas tend to involve the subdermal lymphatics. So I would say erysipelas is a little bit more superficial than folliculitis. Cellulitis, of course, involves even the subcutaneous fat layer, and the fascial layer, of course, necrotizing fasciitis. So, and any questions so far? Okay, so the lecture may be very dry, but trust me, when you see it, you will never forget necrotizing fasciitis. Anyone has seen one before? Yeah, they usually come in and they get operated within the night, and what we usually see is a huge wound, and we are, as plastic surgeons, we are then left to deal with the aftermath, usually with multiple skin grafts, vac dressings, debridements, and you have to end up controlling their diabetes, stabilizing them hemodynamically. Okay, so we are almost approaching 1 hour, 2 hours? How long have we been?
1 hour.
Okay. Okay,
Does
so are we
everyone
making
want
the
a
time?
does everyone want a break now, or should we continue? And we can take questions at this point as well. If you want to send them to me or Calvin, or just like in the chat to everyone, so everyone can read it. Otherwise, is anyone against having a 5-minute break? Yeah, so we can give Mr. Chu a break for water as well.
Graham says it's made a statement. It's affecting muscle fascia.
Yeah, that was earlier about
Okay, sorry.
the
He was answering your
yeah.
question about necrotizing fascia. Yeah.
Okay, so there are multiple fascial planes to be fair. There is subcutaneous fascia and there's also deep muscle fascia. So any of these can be affected in necrotizing fasciitis. And the deep muscle fascia tends to cause much more damage because these tend to be detected much later.
So Sonia has a question. She's asking
Oh
how,
yeah, I see it. Yeah.
How
do you distinguish between cellulitis and necrotizing fasciitis when necrotizing fasciitis has not progressed to gangrene?
That is the key question, and I want to emphasize that in the early stage, it's almost impossible to distinguish just by looking at the area affected alone. And I've personally seen cases where they progress from cellulitis to a necrotizing fasciitis. So these two conditions might not be mutually exclusive, and it can start from one and develop into another. But having said that, in an exam situation, the answer I would give is in necrotizing fasciitis, the pain and the tenderness, it tends to be much more severe than cellulitis. Usually, if it's cellulitis, patients do feel better when they elevate their leg, they ice it. Whereas necrotizing fasciitis, it may appear like a cellulitis, but the moment you press on the area, or even if you go above the area of cellulitis, they get this very, very tender, they almost jump off from the bed kind of pain. And if you come back in about 4 hours, you will find that the pain has progressed to one level higher. So clinically, when I see the patient, I would draw a line around where the pain stops. I come back in 2 hours, I check the pain again, and if it goes higher, and the reddish area of the cellulitic area starts changing into purplish or darker color, indicating that there's gangrene or skin necrosis, then that to me is a definitive diagnosis of necrotizing fasciitis. So in a situation where the anesthetist may think that you are overreacting, so some authors have shown that they can do what we call a rapid diagnosis by making a small incision, a 2-centimeter incision under local anesthesia, dissect down to the fascial plane, use a sterile glove finger and feel the fascia. And if you can feel that your finger goes around the fascia almost without resistance, then that is another diagnostic criteria to sort of guide you, And in certain countries where MRI is readily available, like in Singapore, we send them in, they get the MRI within 20 minutes. The radiologist reports it. Sometimes we can use that as a guide, especially when they're not fit for operation or the anesthetists feel that there's the surgery is high risk, because they're hemodynamically unstable. So to answer your question, so pain and tenderness, so go by clinical. Do not say that, I would do a white cell count or aspirate the fluid for bacteriology. Those are confirmatory tests. Those are not clinical diagnosis. Yeah. Does that answer your question, Sonia?
Oh, yeah, she says yes, thank you. Also, following on that, Mr. Chu, like if so you said we do all these tests as like confirmatory on a confirmatory basis. So when you see a patient and you are considering NECFASH as one of your top diagnoses, then would you then send them directly to theatre, or do you do like normally for like regularly, if you did see one, like, you know, do you normally just do the tests then send them to theatre, or are there cases where you know it's so urgent that you just like send them directly to theatre? What's the normal sequence of things?
Yeah. So if I get your question correctly, what you mean is how do I decide when to bring? So
like you said all these tests are confirmatory. So when do you do them all the time, like as a regular thing, or do you? Yeah.
No. So what I wanted to highlight in this earlier slide was that in a clinical setting where the patient gets admitted via the emergency department, they would have done a basic blood screening test, yeah, and then as say for example the on-call SHO, you go and review them. This would be readily available. So this scoring system was developed as a predictive tool to guide the clinician whether or not the risk is there. And so if you see the patient and he's otherwise well, you know, having a little bit of tachycardia, the limb looks red and swollen, but he insists that he's okay, and you do all these blood tests and you can see that the test shows that all these scores are very highly positive, then that guides you, you know. In contrast, if someone with diabetes, you know, they don't react that strongly clinically because they're immunocompromised. So then they may appear more sickly, but if the risk is lower, then you can maybe hold off and wait a while longer. But having said that, even this score is although is accepted, is validated, but there are authors who say that, you know, this cannot override your clinical decision. It can be an adjunct for you to decide. And as with all things, where as a say for example a surgical SHO, in deciding or not whether to call your consultant to prepare for surgery, what you need to do is to tell them, okay, these are the things that I've done. Clinically, he is septic, you know, he's unwell. The redness is worsening over the last 2 hours, and the score that I can see from the test that has been done is this, you know. So that could help you. But I would still, you know, go clinical if let's say, because not everyone believes in this scoring system. So for me, it is very important to look at the patient, come back, follow up, and you know, a lot of times they will tell you, "Oh, doc, I'm not feeling so great," you know. So these are signs that I see, and I will tell them, "Okay, let's watch closely." Does that answer your question?
Yeah. Just, you know, yeah, like because it's clinical diagnosis sometimes, I suppose.
Yeah, no, it's a tough it's a really tough clinical entity to be managing, and like I said, if you've seen one, you'll never forget. You will either pat yourself on the back or you regret it for the rest of your life. Yeah, if you miss one.
I
So
actually did see one in Baltimore, but I didn't closely look at the patient. It was just a huge fight between the general surgeons and the plastics team, because the intern actually caught it. She thought it was NECFASH, and there was this senior attending, like the consultant there, who actually in the two departments. So that's all I remember.
So who was proven right? If you don't mind
So
me
the intern was right, and yeah, but obviously she didn't get an apology. But I think, you know, before I left, what they were talking about how they wanted to get the other department to apologize to her, but I don't know.
Yeah, so sometimes it's important to stand your ground because I didn't include anything. See, Fornis gangrene is a very specific necrotizing fasciitis, you know, and can anyone see this? Yeah, okay, let me just zoom in. So this is post debridement, but before that it was all swollen, very, very tender and pain extensive. So frequent times we get cases where the where, where the testicles tend to be very, very difficult to treat wounds. Okay.
Any other questions? You can also unmute yourself if that's easier to ask a question.
So I'm thinking maybe the next one we can start with a bit of burns. I think burns is an important topic, and I think most people might not have been exposed to burn injury. This is a topic that's close to my heart, and I can talk for hours on this, but let's give everyone a brief overview on that. So shall we take a break or?
So does anyone want a 5-minute break, or should we continue? Do you want a 5-minute break, Mr. Chu, to get
I'm good.
drink?
I'm good.
Good. Okay, well, I think no one's saying they want a break, so should we
I
continue?
mean, if you do need to, you can feel free and just you know, go for a while. So yeah, let's do burns, and then maybe we come back to wounds again. Yeah.
Okay.
And what I want to show here is okay, this is a very nice diagram of a very nicely illustrated burn injury. Yeah, so you can see from here it's a healthy tissue. This is first degree burns, you know, affects the epidermis. Second degree burn, you can see that the dermis is affected. Third degree burn, you know. But what sorry, I'm not sure who are the other audiences who are in the audience that I can ask, but feel free to just chime in.
You can go to participants and yeah, you can pick.
Oh, that's all?
Yeah.
Oh gosh, I'm so bad at this. Oh yeah, show manage participants. Okay. How about okay, how about Ama? Would you like to try again?
Unfortunately, I'm not very, very good with burns. That's all.
Okay, just hazard a guess. What do you think? What do you think I have a beef about this particular diagram that is very, very well illustrated? So the answer is here. Yeah.
Is going into the muscle a bit? Maybe.
Yeah. Well, we don't generally have a 4th degree burn. Yeah. Basically, 3rd degree burns basically indicates that the full thickness of the skin is burned. So in a 4th degree burn, it's no longer affecting the skin.
Okay.
So it's affecting the much deeper structures. So these are more like ESCA, yeah. So in a exam setting, I wouldn't say there are 4 types of burns. Yeah, I would just limit to 3. So it's 1st, 2nd, and 3rd degree burns. And which do you think are the clinically more relevant burns? Is it 1st degree, 2nd, or 3rd?
I would say 2nd and 3rd, because I feel
Yeah.
1st degree. Yeah.
So in our clinical practice, 2nd and 3rd degree burns are generally the ones that are clinically relevant. 1st degree burns are usually managed at the GP level. You know, these people, they get a bit of redness, swelling. 2nd degree burns are the part where we come in. 3rd degree burns, generally any GP, you know, untrained doctor or even lay people will be able to tell you, you know, that 3rd degree burns is basically very deep. You know, the skin is white or is leathery. So second degree burns is a big entity by itself, and you can see in this diagram, the key is here. Okay, the key is basically this layer, the dermis layer. Okay, so second degree burns basically means dermal burns. Okay, and dermis can have how many layers? Anyone remember their pathology? So you have the deepest layer being the reticular dermis, yeah, and I can't remember the rest. Dermis burn determines how we manage the second degree burns, whether or not they end up with skin graft or they end up with dressing, conventional dressing or conservative dressings, and that would then tell you whether or not you need to go in. So why dermis is such an important area? Why do I not focus on, say, for example, the epidermis or the subcutaneous fat? Why do you think dermis is important? Sorry, dermis is here. So dermis is where all your organs of the skin lies. You know, your hair follicles, your nerve endings, and at the basement membrane, that's where all your melanocytes, your stem cells are. So these layers, this layer is particularly important because of the fact that if this layer is affected, then you won't get a normal healing. If you get half the dermis getting burned, for example, here, then your hair follicles might still grow, your nerve endings will still sprout. But in the second and deep second degree and the third degree burns, these tend not to regenerate. And that's where we will advise whether or not he or she requires a skin graft. Yeah. So let's move on to some clinical photos. Okay. So Kelvin, would you like to describe this photo? So this is a 42-year-old gentleman. He was cooking and there was a gas explosion in an enclosed room. He's a smoker. What do you think you want to say about this photo?
So there seems to be some form of a superficial burns injury or some form of tissue destruction at a superficial level, or maybe a bit of partial thickness, but I think it's superficial. Probably around the forehead, the right temple, and the right cheek as well.
Okay.
I think it's well demarcated as well.
Mm-hmm.
Yeah.
So basically, again, I go back to what I explained to Amma earlier. So when you first describe in a clinical exam, you know, you would say, okay, this is a photo of a middle-aged gentleman who appears to be unconscious, lying on a trolley. Yeah, I can see that he's being intubated. Yes, there's a tube running out from his mouth. This picture shows the right side of his face. So again, you know, from an overview, then you zoom in, then you can collect your thoughts and start describing. So you can then say that what strikes me is that there appears to be lesions around the face, specifically on the nose tip, you know, on the forehead, cheek. You know, his eyes are closed, but I can see that the eyelashes appears to be shortened. You know, there's this appearance on the hair, and here, you know, you might see some curling. So given the history of gas explosion, you might want to describe that there is singeing of the eyebrow, of the hair, of the facial hair. There's loss of the epidermis, definitely, you know, and you're right, is quite well demarcated. Yeah, and what do you think? What do you think these are pink in color?
Is it just erythema because it's reached the dermis layer where the vessel?
Yeah, so again, in a pigmented individual, it's very hard to see erythema. By the time you see the skin being white or pale, you know, short of having vitiligo or hypopigmentation, these tend to mean that there's complete loss in the epidermis. Yeah. So in a situation where you get burned, Usually a second degree burn, you will see, what do you commonly see? Say, for example, you burn your hand on the kettle, you know, or hot noodle, you would see blisters, right? And these blisters would then rupture, revealing the exposed dermis underneath. So this is basically exposed dermis. Yeah. So the epidermis is gone. So once the epidermis is gone and then you see dermal injury, these are automatically second degree, or what we call dermal burns. So to make things easier, we have moved away from first, second degree, third degree burns to superficial burns, dermal burns, and full thickness burns. So full thickness burns is when you lose the pink color. So maybe this is not a very good example. So let me just illustrate with a few other examples. So this one is a magnified view of the hand. Yeah. Cleo, what do you think? How would you describe this clinical photograph?
So this looks like the right hand of like a child or teenager.
Yes. Yeah. A young individual. Yeah.
Yeah, and there are many lesions on the radial side of the arm and the hand. There is, I can see some de-epithelialization of the lesions, and some of it has a bit of like reticular or papillary bleeding. And other bits seem to have gone completely pale, so that might be a deeper burn. Like, yeah, just like
This
right
area,
around, yeah, like that looks really pale. So that
compared
bit
to this
over there,
area,
yeah, that looks like there's still like papillary or reticular bleeding from the dermis.
How
And
about these areas?
Yeah, and those areas look more superficial there. The epidermis looks fairly intact, but I do notice some erythema around the areas, looking more like looking consistent with a first degree burn, and like the for the second MCP joint over the second
this one, yeah, okay,
yeah, that one, yeah,
okay.
that looks very very moist, or like, is there like some kind of there's some weeping? Yeah, I think that's
okay.
that.
So I agree with most of your assessment, but what I would like to add is you can add that there's crusting, indicating that the fluid is dry. There's some areas, like you correctly said, they are wet and still weepy. And so what if I tell you that there had been no burn injuries in this patient? What if I said that he went to the gym with his dad and this is how he appeared in the emergency department?
Friction burn?
Exactly. So yeah. So I'm glad you mentioned that. So not all burns are from scald injury, fire. So friction burns is also another type of burns, and they can mimic very much like a actual burn injury. And the pathophysiology is the same. Basically, there's loss of certain areas, structures. Like in this case, this area here you can see is almost gray, non-blanching, you know. And near the periphery, you can see much less whitish discoloration. And if you have a chance to examine the patient, you would then press on these site areas and see whether or not there's blood flowing in. So again, so the main pathology here is a deep dermal burns of the extensor surface of the wrist and arm. Yeah. And these require immediate attention, much like any burns will. So does anyone know of any other types of burns?
Chemical, electrical, thermal.
Yeah.
Radio burns?
Yep. Radiation burns, you mean?
Yeah, I remember I once touched was it a walkie-talkie, and it burnt me from inside out. So that's
Wow.
it. Yeah.
I'm not sure what kind of burn is that.
I'm not sure too.
Yep. So we have radiation burns, we have chemical burns. So chemicals can be any kind of caustic solution, be it alkaline, acidic, or even some other unknown chemical. It can happen with solids. For example, crystals, caustic sodas. When it get into contact with skin, even pure sodium and potassium compounds can burn. Rare burns would be things like radiation, of course, and I think one of the things that we sometimes also see are electrical burns. And electrical burns can be very, very deceptive because there might be one entry point and an exit point, and you don't see any injury superficially, but the patient comes in with severe pain. So basically, these kind of electrical burns can pass through structures deep within your body. More specifically, they pass through muscle. So why does electrical burns pass through muscle compared to, say, skin? Anyone want to hazard a guess? So basically, it has got to do with conductivity, right? So what are muscles? Muscles are basically actin myosin fibers, right? And what conducts through the muscles? These are basically electrical signals. So muscle being much more fluid filled, they have a lot of nerves. So these tend to conduct electricity much more than the skin, which is basically a much higher resistance. Okay, and if it passes through organs such as the heart, it can interfere with the electrical signals in the heart, and they can come in with arrhythmias, they can come in with myocardial injuries, heart attacks. So these are specific type of burns that we sometimes see. Okay, so this is an easy one. Anyone want to just quickly describe and say what this is? Yeah, so basically, it goes without saying, this is she fell asleep while sunbathing on the beach. She wore a pair of sunglasses, and you can see that majority of the burns are in the exposed parts of the face and the body. There's no blistering. She's otherwise very well taking a selfie. So these are superficial burns, or what we call first-degree burns. So the difference between a first-degree and a second-degree burns is that they don't get blisters. And sometimes when blisters break, they may appear to be a little bit similar, but the difference is these wounds, they are not weepy. They don't turn into blisters. They don't weep. But what they do is they will dry up, and they get very, very painful. And after a few days, they tend to peel, and the new skin develops underneath. So this is basically a first-degree burns. Now, how about this one? Anyone? Quite a dramatic photo, yeah. So again, it's a gas stove explosion. Ama.
So this patient's got extensive burning across the whole face. If you start from it covers the whole face. From the top, you can notice this blistering, large blisters from the forehead to the cheek, all the way down to the chin area. Patient also has, I would say, I'm not too sure, but around the nose area, there's like there's a depigmentation just slightly on the side, yeah. And you see a lot of greyish, it's quite greyish too on the nose and the forehead too. And I would say, is there pus? Yeah. Is that pus?
So she gives a history of applying something on these areas. Yeah. So these are not pus. Okay. And in any case, this is an acute burn injury. So in our society, people like to apply all sorts of ointment. Some people apply toothpaste, vinegar, turmeric powder. Some of them apply hair cream. Yeah. So basically, yeah. So these are to confound you. So what I wanted to highlight is, number one, these are big blisters on the face. Yeah, indicating that these are at least a 2nd degree burn. Right? Agree?
Yeah.
But would you know whether or not they are 3rd degree offhand?
I personally know, I can't see.
Yeah. So basically, they can. Some areas might be 3rd degrees, exposed areas like the nose here. But more importantly, without de-blistering and scrubbing away all these dead epidermis, you wouldn't be able to assess. And so what I wanted to point out is, yes, so this is at least a 2nd degree burn, could be a 3rd degree. The reason why I say it could be a 3rd degree is you can see a lot of this singeing of the eye, of the hair, of the eyebrow, the eyelashes. So these are basically burnt off. They're not, and burning off means they are not scald injuries, they're not water, they're not liquid-based injuries. So this can be fire. So when it comes to fire burns or flame burns, the temperature can be in the hundreds or even thousands of degrees. Yeah, and even a flash explosion, fire explosion can lead to 3rd degree burns. But why do I show the face here? What is more striking to you in terms of not just the skin, but what about the other things? Like, say for example, if I show you this, what is this?
You can see swelling of the face too, like edema around the lips and eyes too.
And she could be unconscious, but what if I tell you she is conscious and she's trying to talk?
Possibly some like damage deeper than into the past the dermis layer that's damaging the nerves. Hence you can't open her eye.
Okay. So basically, what is very striking here is that there is a lot of edema of the lip.
Yeah.
There's all this outward turning of the inner lip. She couldn't open her eyes. She's trying very hard. So and you can see that the eyelashes are burned. So you would want to make sure you have a look inside, yeah, and to see whether or not the cornea is actually burned.
Okay.
So if there's corneal burn, then that's an emergency. You need to activate the the ophthalmology colleagues, yeah. And what I didn't mention is airway injury. So the nose is completely burned, the mouth is completely burned. So sometimes people take a deep breath when there's an explosion, and they can inhale flame. Or in a trapped environment, they can inhale smoke. And in cases where they are burning plastics can get burned and they can release cyanide gas and all these toxic byproducts of plastics. Okay, so it is not just for a plastic surgeon. It's not just for us to treat the cutaneous burns, but rather to identify all these major emergencies to their life. Okay, so airway burns, eye injury, and what happens when you admit patients with burn? You give them hydration. Yeah, in a large surface area burns, you do give them a lot of fluid. What happens to the airway when you get burned and you infuse tons of fluid? Very soon their larynx would swell, yeah, and further fluid infusion would give you even more edema, and patients can suddenly collapse in the ward if these are not addressed. So the first thing is to secure the airway. You don't even bother with the burns. So in this kind of situation, we intubate them in the emergency department. We bring them in immediately to do a scrub down, clean up the wound. They get sent to ICU. And what happens after, say, a couple of days? Say, for example, you have extensive airway burns. You breathe in a lot of soot and smoke. They get acute respiratory distress. The lungs react in a very major way. Their lungs get flooded. This ARDS is also a reaction to infection. So they can be very, very unwell. Even without say a burns injury. Say for example, someone comes in with a bit of singed eyebrow but no cutaneous burns. But when you do an X-ray, there's lots of soot inside and there's a lot of smoke particles. So these are something that you need to watch out for. Yeah. Okay. So let's go through very briefly. So this is what that was termed as 4th degree burns. Okay. So this lady fell asleep on the radiator after some drinks, and then when she woke up, there's this deep dark patch And you know that there's a contact surface here and a contact surface here. And this area in particular, you can see what we describe as eschar. So eschar is an adherent necrotic deep patch. So in this case, this is determined 4th-degree burns. But generally, this we just say it's a full thickness or a 3rd-degree burns, yeah. And it can go down to even muscle layer. So, but for all intents and purposes for exams, we usually say that this is a 3rd degree. Now, chemical burns. So this is a hydrochloric acid burns, and what is being shown here, Cleo?
So this is photo of a young
Yeah,
gentleman.
okay. No, I'm just asking you about this.
Oh, this
Let's
bit.
dispense with the rest.
Is that like the pH, like?
So these are usually used as a urine dipstick, yeah?
Yeah.
So in this
But it
case,
has
we are
small
using it to
colours.
measure the pH.
Oh.
And so in a acid burns, we want to make sure we neutralize these acid. Why is that so?
To arrest the but actually not really, like, wouldn't you, if you neutralize it, could
And so
it
my question is, why would you want to neutralize it? Yeah, so chemical burns are not like thermal burns. So it's not a direct transfer of heat. Yeah, it is a chemical reaction. For certain acids or alkali, the reaction tends to be continuous. And if the pH is not neutralized, basically your chemical compound continues to react with the soft tissue. Things like hydrofluoric acid, for example, they can burn all the way down to bone. And so the treatment for these kind of burn injury is rapid irrigation. So that's what you find in a lab or an industrial setting. They have like showers where once they get injured, they immediately run to the shower and then they wash it out, you know, to make sure the concentration is diluted. You know, and in a hospital setting, what we do is we test them for pH, and we document that pH has been diluted from say 3 to 7 to neutral. Yeah, so that's
so when you say neutralize it, you were just doing like irrigation, right? Like
yes, yeah. There
yeah,
are
'cause
specific agents to counter concentrated acid. For example, hydrofluoric acid, we use some alkaline compound. Sometimes we can do that, or calcium gluconate, which is like a buffer solution. So that can be done as well. Of course, you don't pour in alkaline alkaline solution because you're gonna cause alkaline burns, right?
Yeah.
So yeah, so all these are a bit too much detail. So what I'm doing is basically just trying to expose you to what to do in a chemical burn situation. Yeah. Okay. And of course, in the face, you want to look at the cornea, you know, etc., etc. Let's not go into that. Okay. So this is one complication of burns. Kevin, would you like to just spot diagnosis? What are these areas? Let's say she was scalded by a hot soup 1 week ago, you know, didn't see a doctor, came back 1 week later, having pain, fever, redness. You see these patches.
Is it?
Yeah.
I'm really not sure, but is it possible that it could be the same thing as the S chart as just now?
Exactly. So, but this eschar or escar is actually green in color. Yeah.
Oh, okay, I see.
Can you appreciate the color? I know the background is green,
yeah,
but this is actually green if you look closely.
Mm.
And if you look here, these are areas that I've re-epithelialized. You can see that it's shiny. Yeah, it looks dry, unlike the rest of the areas surrounding these red areas, the greenish areas. So you can see around these greenish areas, there are all this reddish discoloration, you know, and she's having pain and it's greenish, you know. So like you correctly mentioned, it's an eschar in the sense that it's a full thickness burn injury. Yeah. But this is not from the original hot soup. This is basically from the fact that these areas did not heal and it got secondarily infected. Yeah, so bacteria went in, it colonized the area, it caused the whole area to become necrotic, and has developed from a what should have been a superficial second degree burn into a third degree. Yeah, so this is what we call a burns wound conversion. So the conversion actually made the wound much worse, and that's the reason why we make sure that we dress the patient, we give them some antibiotic cover if need be, and we tell them to come back for regular change of dressing. So infected burns is another aspect that another entity that you sometimes see in the emergency department. Don't say that this is a third degree burn. Yeah. Okay, let's move on. So so this is a summary of what we have just discussed for the last half an hour. First degree, second degree, or what we call partial thickness. Third degree is full thickness. You know, exam, you just rattle off, you know, absence of blisters is what we see as first degree. You know, then second degree is usually red, you know, because there's still circulation. Third degree is basically dry, leathery, because there's no circulation. And what are the causes? Usually sunburn, you know, these are temperatures that are less than, say, 70 degrees, 60 degrees. These are basically prolonged contact, you know, causing the burns. And then, of course, second degree would be hot liquid. Anything above 60 degrees can cause potentially burns. Yeah. And then third degree, we usually see with much more severe thermal transfers, fire, electricity, you know, hot liquids, prolonged exposure. And this shows an electrical burns. So you can see that the center part is the entry point, and then there's third degree burns here. Basically, this is fourth degree. And then there's this superficial burns. And you can see that there's also burn here, you know. So and electrical burns happens when there's passage of current. And when the current passes from here, then it goes down the skin and comes out here. This is what we call an entry and an exit point. Frequently, it may be very, very tiny, say, for example, fingertip. And then on the other hand, you see another fingertip burn injury because they are handling the socket, you know, so both hands are injured. But a lot of times the electrical current passes through the body and it can cause damage to the myocardium. So that's the special thing that you need to watch out for electrical burns. And when there's specific muscle injury, muscle tends to break down and they can release a toxin, a very specific toxin. Do you know what it is, Kevin? What is the muscle breakdown product that you sometimes see in, say, necrotizing fasciitis, compartment syndrome, you know, major crush injuries?
Is it like
Yes, exactly. Excellent. So when you have rhabdomyolysis from whatever cause, you know, the muscle breaks down and they release massive amounts of toxic byproducts. So besides rhabdomyolysis, which releases myoglobin, by the way, you know, if you go back to your physiology, what happens when all these cells break down? What gets released, which can also be life-threatening? What is high concentration within the cell, which is low? Yes, exactly. So potassium is another thing. So if they have massive myocyte injury, you know, the massive release of potassium, and you get myocardial injury, potassium itself can cause arrhythmias. So, you know, these people can suddenly deteriorate and they get cardiac arrest and they die very fast. So the higher the voltage, the more the muscle injury, the longer the course of the passage of the electricity, you know, the more dangerous. So, okay, just interesting points, but you do see these when you are posted to the emergency department, for example. So these are things that it's not readily evident, but it's good to know. Yeah. Okay, so let's get to the boring parts of burns. So how do we measure burns? It's basically the rule of nines. Yeah. So the rule of nines states that each parts of your body can be divided into portions that can be calculated as 9%, with the exception of the groin area, which is 1%. In this case, the entire front of the lower limb is 9% each, abdomen is 9%, the chest is 9%, the head and neck area, including the scalp, is 9%. So the entire arm is 9%, so 4.5 and 4.5. So, and the last one would be 9%. So this is a very simple, rule of thumb that you can use. And to add on to it, if let's say they are smaller than 9%, you can use the palmar surface of your hand with outstretched fingers to approximate 1% of body surface area. And this is true even for younger individuals, for kids. Yeah. So this is what we call the Wallace rule of nines. So for children, they tend to be a bit different in terms of the calculation. So the rule of 9 does not apply to children. So bear in mind. There are also other forms of calculation. I won't go into too much detail, but this is the quick and dirty way of doing it. There's also the Lund and Browder chart, which lists down each section and the percentages, and you can use the chart and measure them. So what are the mechanisms? We've gone through it: scalding injury, chemical injury, fire, radiation, electricity, friction and burns. Friction and cold injuries are also considered burns sometimes, yeah. And pathophysiology-wise, burns injury, as we have seen over the last few photographs, they are not homogeneous. They can have different zones, and the deeper zones are usually zones where there's no more circulation. They are white, so they get coagulation. Stasis is when there's compromised circulation, where the capillaries break and you see staining, red color staining. Hyperemia is when there's increased blood flow, so there's a lot of reaction going near the wound, and these tend to be very, very angry and red looking, but they are basically increased blood flow. These are reaction of the body due to the inflammation and to help with the injury and bringing in all your neutrophils. So history, cause is very important. In fact, a lot of times the emergency physician would immediately intubate them before you are able to take a history. So sometimes it's important you speak to them, because once they intubate, there's no way they're going to extubate for the next few weeks if there's a lung injury. So I do tend to insist on talking to them before they go under, unless they are really compromised, in terms of they can't talk, then we do. But otherwise, history from the patient is very important. So you need to establish whether or not there's explosion. So when there's explosion, you were worried about barotrauma, you're worried about injury to internal organs, contusion to the brain. Flash fire, if there's a flash fire, you want to see whether or not they've inhaled smoke. And water injury, if there's a partial drowning, and so on and so forth. And what kind of chemical is in the water. Time of injury is very, very important, because it determines how much fluid we need to give in how much time. So fluid hydration is very, very important. Place of occurrence, whether it's enclosed, whether or not there's presence of chemicals, noxious fumes, associated trauma. Investigations, the usual blood panel, arterial blood gas where there is suspicion of carbon monoxide poisoning. We measure carboxyhemoglobin levels. And for smokers, they are different from non-smokers. So there is a chart as to what percentage is acceptable for smokers and non-smokers. Coagulation profile, myoglobin levels, if you suspect electrical injury, crush injury, 12-lead ECG, if you suspect there is injury to the myocardium. And needless to say, the ATLS, Advanced Trauma Life Support Protocols, airway, breathing, circulation, and so on and so forth. Avoid hypothermia in temperate climates in winter season. Ironically, burns are more common in winter seasons because of handling of fire and hot liquid, and how much fluid loss you need to assess, and of course, remove any constrictive jewelry, necklace, clothing. Airway management, have a low threshold for intubation, high index of suspicion for airway injury, swelling. So we do nasal endoscopy where it's available to assess for soot in the airway. Swelling can be progressive, and then it can turn very rapid once resuscitation with fluid has occurred. Then when you intubate, you need to make sure that you also treat other things like hyperkalemia. Preparations, for example, in the field, You want to prepare for cricothyroidotomy if there's no endotracheal tube available, emergency tracheostomy, and so on and so forth. So this case shows the signs that might not be readily present for airway injury. So you can see on the left side of this photo, there are no cutaneous burns on the face, but you can see hints of injury to the hair. Similarly, very mild swelling of the lip, but you can see extensive loss of eyebrow, eyelashes. So again, these are signs. So when you talk to them, they may complain of hoarseness of voice, sore throat, pain on swallowing. And this is one of the things that we see when we do a bronchoscopy. You can see all these white color casts, which are just basically exudates that clot up. You can see soot within the airway. Sometimes you can see fluid, on the bottom part. It's not readily evident here. So a bronchoscopy is a deep scope. So you basically go onto the trachea. This is the main bronchi. But we can do a nasal endoscopy where we just look into the nose and upper airway and also the vocal cords. Carboxyhemoglobin level that I explained earlier, if you're not a smoker, the normal range is 0 to 15%. Anything that is more than 20%, it can potentially be fatal. And above 60%, usually death is inevitable. So a lot of them, most people, when they are trapped in a burning structure, they can die from carbon monoxide poisoning. So complications, what are the complications of major burns? Early, as you mentioned before, carbon monoxide poisoning, hypovolemia, shock, hypothermia. Late acute respiratory distress syndrome, which are manifestations of inflammation in the lungs. Renal failure due to due to circulatory shutdown. So once your kidneys fail, your liver starts to fail, and multi-organ failure can set in. Due to the loss of skin barrier, you can get overwhelming sepsis. Curling's ulcers are basically gastric ulcers from stress. So long term, you get problems with scarring. Marjolin's ulcers are cancers that develop from chronic ulcers that do not heal. Contractures that can prevent movement and function from recovering. So what are the traditional treatment for burns wound? Say, for example, superficial wound. We sometimes use silver sulfadiazine. I believe this is still common practice. Basically, these are silver ion, silver compounds that precipitate and helps make the wound sterile and kills most bacteria. Iodine is sometimes used, but they are inactivated by plasma. Gentamicin, Bactroban ointments, they can lead to antibiotic resistance. Non-adherent dressings like Tugra and Gelonet, but unfortunately these tend to dry out after 40 hours and needs to be changed. Nasogastric tube feeding for people with upper airway and facial and oral burns. Anyone with 15% burns and above, they tend to have problem with swallowing and nutrition. They can go into catabolic states where the body is trying to heal itself and it starts breaking down the protein and muscle, and this can result in very poor wound healing as they go by. And for pediatric patients, they need even more calories for every percentage of burns. So there are multiple protocols that we can follow. Other supplementation, albumin is very important because a lot of the exudate contains albumin, and they lose albumin and they lose oncotic pressure, they get edema. And if you fluid replace large amounts, you can dilute the albumin as well. Hemoglobin replacement for dilutional anemias. Sodium supplement in very young children, especially because they lose a lot of electrolytes, and they can go into seizures if you don't catch up with the electrolytes. So that in a major burns unit, our main morbidity is from severe burns. So severe burns is considered to be anywhere between 50% above. So major burns in our hospital is classified by anything above 15-20%. Severe burns over 50%. So as we mentioned before, there's many things that can go wrong in burns besides just a cutaneous injury. you get problem with fluid, you can get problem with the lungs. So it's very important that we remove all these non-viable skin. So all the skin that have third-degree burns, basically they don't recover by themselves. And if you don't remove them, they become a petri dish, because all these are dead dermis, proteinaceous material. Second thing is to manage fluid, electrolyte losses, prevention of infection with broad spectrum antibiotics, management of organ failure. So they go into a lot of, so like we mentioned before, rhabdomyolysis causes release of large amounts of myoglobin, and myoglobin gets trapped in the kidneys and can cause renal failure. And subsequently, the lungs and liver can fail from antibiotic treatment, from sepsis, and nutrition in order to help with the patient's recovery and to prevent them going into catabolic states where they break down their own protein. So secondary consideration will be to minimize donor site problems. For example, we use cadaver skin, we use scalp skin, we do micrografting where we expand the skin by a factor of 30. And then finally, scar and contracture prevention. So I won't go into too much detail of this. I believe these are beyond the scope. So this is just an example of how we harvest skin. You can harvest a skin with basically a dermatome. It can be a manual dermatome or it can be a mechanical one. The skin is then meshed into a skin mesher and spread into different ratios of stretch. So a partial thickness skin graft, which is what we do for this kind of skin, can stretch up to 300% with correct measure. A full thickness skin graft is usually done for areas that are over joints, where you need pliability. But a full thickness skin graft can only be harvested from areas such as the supraclavicular area where there's excess skin. You can harvest from the groin, and these are very limited areas of skin availability. So what happens when you have large surface area burns? Okay, before I go to that, people will ask you, how do you prognosticate burns? So one of the common examples that we do is the box score, which is developed more than 50 years ago. This is a very simple scoring system where the mortality equals to the age plus total body surface area. So age is age above 20. So if you are, say, 30 years old with 60% burns, then your mortality would be 70%. So the older you are, basically the higher the mortality. But as our technique and our burns management improve, we can have mortality rates that are more than 100%. So people have gone on to develop different types of modification. So we won't go into that detail, but suffice it to say, in a basic level, you can roughly assess prognosis by using these scoring systems. So again, this is the electrical dermatome. This is the measure. You can see the skin is being spread. So for someone with 50% burns, you wouldn't want to harvest another 50% of the body to graft it. So you can harvest, say, 20%, but even then you leave 70% raw area. So the more you harvest, the potentially you can cause more injury from increasing raw area, fluid loss, blood loss, as well as the bacterial contamination of the wounds. So this photo shows a circumferential full thickness burns. I shall not test any one of you with this. So basically what you see here is when there is third degree burns where the skin is all leathery, you can see that they are white, and even the epidermis is burned onto the dermis. And when it's circumferential throughout the whole body, what happens is the burn skin becomes so tight that there's no more pliability. So these people come in with shortness of breath because they can't breathe. So we do immediate bedside escharotomies. So we slice open the areas where it's very, very tight. And immediately after you do an escharotomy, you can see that the whole thing stretches open and they can actually move their chest. So this is, of course, a very dramatic representation of an escharotomy. We have escharotomies for the limbs. Commonly, it is the limbs, the upper and the lower limbs. So if you see a circumferential injury over here, which is full thickness, you have to think about immediate or at least early sclerotomy. And I'm talking about, within 2 hours, because it takes as short as 2 hours for your muscle to undergo necrosis, and they get into compartment syndrome, and you make the situation worse. So full thickness burns can constrict blood vessels. It impairs tissue perfusion deeper down. It happens when there's extensive tissue damage from a deep burns. It can lead to massive cell death from the compartment syndrome, release of potassium and myoglobin. So this slide is a very busy slide, again showing what the normal alveolus like and what happens when the lungs are injured. So you get loss of surfactant, you get translocating fluid, you get neutrophil migration, and needless to say, your lungs basically fill up with water. So I shall not go into too much detail here. Now, I was mentioning full thickness skin graft. So this is an example of full thickness burns. You can see it's completely white. These are not really blistering, but rather the epidermis being burned onto the dermis. And we take from the groin area, close primarily, and we graft it over the joint surfaces where mobility is important. So this is an example of a full thickness skin graft. For a major burn injury, what we do is we use cadaver skin. So you can see these are skin that is donated from cadavers, and hence the difference in pigmentation. At the same time, we do micrografting. So these areas are scalp skin grafts that we harvest after shaving the patient, and we lay on micrografts. So a small area of skin graft can cover the entire abdomen, for example. In our unit, we also have culturing of epithelial cells. Basically, we harvest a small piece of skin from the patient, and we grow into sheets of keratinocytes. So a small piece of skin can be harvested, grown into a culture, and after about 3 weeks, it is then applied onto these areas. So these are way too advanced, so I won't go into much detail. This is the electron microscopy showing how these keratinocytes grow in the lab, and they become confluent after a while, and we can graft these unicellular structures there. Now, in children, we try not to graft these patients because they heal well, their circulation is good. You can see in this area, this is a skull injury. Most of the wounds are fairly superficial. Maybe there's a bit of shininess over here. So what we've done is we've used BioBrain, which is a structure that mimics the skin. So the BioBrain layer has got a silicone top layer, and is impregnated with nylon in the bottom layer. And these nylons are also impregnated with collagen. So collagen, when it contacts a raw surface, tends to cause clotting of the plasma via the extrinsic pathway. And the silicone layer is sort of a waterproof layer. So they tend to heal very well. It allows us to look at the skin, and we don't have to remove the dressing. And about 3 days later, we can see that the wound is healing well. Again, another application of BioBrain, you can see after about 1 week heals. So for children, comfort is very important. This is the same boy after about 15 days. So, so indication of BioBrain obviously is only for superficial burns. Yeah. Another example of the cheek. Let's move on. Suprata. So there are many more skin or dermal replacement products that is coming onto the market, and this is one of the product from Germany made of polymer. And I'm sure everyone have heard about this viral video of how they've been using tilapia fish skin. So these are in countries such as South America where they don't have a cadaveric skin bank. So, and they come in, they use processed. These are basically fish skin that are gamma irradiated, and they apply onto the wound for a moist layer as a temporary barrier, and these have been proven to be successful, and it's now FDA approved for use. So I would like to conclude to say that burns care is a very complex topic. It involves multiple disciplines. We have mass casualty in burns, which are a real thing, and when it happens, everyone has to scramble, and you have to make sure you exclude other injuries that are not readily obvious. So more than 50%, basically they need to be treated in a specialized unit, high risk of mortality. Pediatric burns injuries are much more time sensitive and critical. So we need to make sure we don't cause them to have hypothermia, fluid loss, electrolyte imbalances, etc. Okay. Any questions so far?
So there was a question earlier. Someone's asked, what's the gold standard method of intubation to avoid aspiration completely in surgery?
Well, this is a bit beyond my pay grade, but yeah, I understand what you're trying to say. So in surgery, we frequently fast patients, and if you speak to anesthetists, you will know that they are very particular with fasting time. Yeah, because if you have a problem with a full stomach and they induce, so what happens, the gastric juices will come up, and they can cause very severe chemical aspiration. You know, acid in the lungs is no small matter. So in emergency surgery, for example, in cases where we need to rush in for surgery, we can't wait. So we have things like rapid sequence induction. We can put in an NG tube to aspirate all the gastric contents prior to intubation. And we can also do things like cricoid pressure, you know, to prevent reflux. If you're talking about burns specifically, the gold standard is always to do a scope first, see what we're dealing with, whether there's foreign body, whether there's soot, whether or not you need to do a bronchial lavage. All this has to be done just before you intubate. So I think does that answer your question? Not so much related to plastic surgery.
Yeah, you said thank you, yes.
That's another topic
question
altogether, yeah. So I don't think I can cover all that.
There's another question. So for patients with more than 15% burns, you said they usually suffer from dysphagia. Is this true even when the burn area is nowhere near the chest region? Is it due to a metabolic response?
Okay, so the reason why I put 15% as a cutoff is, I mentioned earlier, 15% is basically a major burn situation, okay? So when you have major burns, you know, number one, you get a lot of stress. So people can get stress ulceration. And 15% burns basically means that they have to go for general anesthesia to clean up their wound. We usually put in tube feeding because of the stress of the burns. They are not in a state where they can feed according to their caloric requirements. So above 15% burns is when it's severe enough that your body can go into this metabolic, instead of metabolic state, in a catabolic state. So a catabolic state is when the body has got insufficient nutrition. They start breaking down their own protein. So you can imagine, if you start breaking down your own protein, what about your wound? You know, you are trying to build a wound. So without with a catabolic state, your wound will get worse. So 15% of your burns might not heal. In fact, when it doesn't heal, you get bacterial translocation, you get infection. So then your body goes into sepsis, and the body's energy is then spent in fighting infection. So feeding is something that we are very, very particular about, because if you don't catch up with the feeding, this is a vicious cycle, and they spiral downwards very, very fast. So I put this statement on because I want everyone to know that you know, if you don't start feeding early, by the time you catch up with the feeding, they are already in the state where the body is breaking down their own wounds. And especially so for the pediatric population, they tend to heal very fast, but once they decompensate, they also decompensate very, very fast. Does that answer the question?
Yes, it does.
Okay.
I think, yeah.
So,
To what extent is plastic surgery associated with the psychological impact of burns and burns management?
so
what is prioritized here? Fixing? Oh, wait, sorry, that's the second question. Yeah. Okay.
okay, to what extent is plastic? Yeah, so do not underestimate the psychological impact of burns, because especially for younger individuals, they're not so much worried about whether or not they can recover, but what life would be like after the injury. And frequent times, even with minor burns, people can get very, very depressed over it, and the action of how they got injured can also impact very largely on how they recover. So for example, if there was a gas stove explosion, and these people can get very, very emotionally affected whenever they even watch TV of people cooking. So you don't want to let them watch a cooking channel when they are burned, for example. So the psychological impact is very, very important. And for major burns where they are decompensated, they are been in the hospital for 3 months, it is important for us not to send them home directly from the hospital. They need step down care, they need counseling, they need psychiatrists sometimes to even prescribe medication to cope with the PTSD. So burns injury is so much more than just managing their cutaneous burns and putting skin graft and letting them go home from there on. So it is it's a very all-encompassing treatment, and I think burns injury are one of the worst things to happen to anyone, and one of the worst ways to go. So even for cases where they have 90% burns, they can walk in awake, conscious, talking to you, because the burns injury is so bad that they don't have fluid loss. So these kind of cases, we know that the prognosis is very poor. We would ask them to call the family members and sort of talk to them and maybe break it to them that this might be the last time they see them, because once you intubate them, they can never be extubated. So they may survive for the next 1 month without having a chance to talk to their loved ones. So these are all very important considerations, and I can go on for a long time talking about that. Yeah.
So I think that answers the question. There's another question though, regarding burns overlying the site of a fracture. Is the approach to management different? What is prioritized here, fixing the fracture or burn treatment?
Yes. So as a trauma reconstructive surgeon, I can tell you burns happen very often for road traffic or motor vehicle accidents, especially for people like cyclists, people who are on motorbikes. They get road rash. So what is road rash? Basically, road rash is friction burns, but with the added problem of tattooing of sand into their wound. So they do get a lot of these wounds. So and sometimes they have, in fact, most of the time they have fractures. So when you see a patient with a fracture that may have been reduced by paramedic, for example, you see that there's extensive burns injury over the aspect of the contact surface with the road. It's very important that you treat it as an open fracture, because sometimes the puncture wound may not be readily evident. So that makes a big difference to the management of the fracture. And if there's any suspicion that there's a fracture and there's a wound associated with it, it could be an abrasion wound, could be a road rash. All this can mean the difference between an open fixation versus a plating. So an external fixator is usually put on if, let's say, I suspect an open fracture. We go in, we debride the wound, make sure the areas that are deep burns is excised, and we can even skin graft them before they start doing the fracture. And in the meantime, we start high dose strong antibiotics, especially if you're talking about environmental contamination. If you have a Clostridium, for example, seeding into the wound, you can even develop things like gas gangrene. So it's definitely something you should not take lightly if you see these kind of injuries in your work. So priority-wise, fixing fracture, yes, but it depends on whether or not it's an open fracture. Yeah. So frequent times, me and the orthopedic surgeons will both go in. We will assess. What he will do is he will check whether or not the fracture is overlying the injury, because if it's an open fracture where the bone juts out from the skin, even that is considered an open fracture, and you may have reduced the bone, but whatever contamination may have gone into the bone. So it is a process where we both discuss and we decide what is the best course of action. So there's no real priority, but rather it's a multidisciplinary approach. But in cases where we don't have a plastic surgeon in a peripheral hospital, then yes, the orthopedic surgeon might decide to do a external fixation first, clean up the wound, do extensive debridement, refer to the plastic surgeon, and they can come from the main unit, and we can then deal with it. Yeah. So yeah, I don't think there's any fixed rule here. Okay, does that answer the question? So I think we've come to more than 2 hours. I'm not sure whether or not you still want to go through the ulcers. What I can do is maybe just a very simple overview, 5-10 minutes.
What does everyone prefer? Should we go through everything, or are
So
people
basically
keen on
what is
sticking-
left, maybe I'll just tell everyone what is left is basically the ulcers, the venous ulcers, the arterial ulcers, you know, and these are fairly textbook kind of thing, you know, neuropathic ulcer and of course pressure ulcer. Now, most of the time in exams, they would stick to venous ulcers. The venous ulcers are by far the commonest. Arterial ulcers can be
Summary of ulcers would be helpful.
Okay. So let's do this then. I apologize for my speed. So okay, just a very brief overview. So for venous ulcers, these are basically related to the venous drainage, where there's insufficiency. It can, most of the time, it is related to varicose veins. Varicose veins are essentially incompetent valves that causes blood to pull back onto the wound. And of course, if you think about a column of fluid, the highest pressure would be at the ankle area, you know, and sometimes what predisposes these people to get backflow of fluid is basically if they have previous things like damage to the deep venous system, if they have obesity, pregnancy, and recurrent inflammation of the blood of the veins. So in these kind of cases, they are typically located at the lower third of the leg. Yeah, and what you see here is usually you get hemosiderin deposits, which are basically dark discoloration around the wound. These are basically breakdown of red blood cells. So red blood cells, when they break down and they leak from the capillary, the breakdown product of iron tends to stain the skin, and you see this very dark stain. And a lot of times these are superficial ulcers because the skin gets damaged over time. And these are usually shallow, flat. They can have moderate to severe exudates, which is related again to the high venous pressure. So imagine a column of fluid again. When the vein is leaky, they tend to get a lot of exudates, especially with dependent position, especially with standing. The base tends to be sloughy because of the exudate. So exudate will harbor bacteria, and this can cause the base to be sloughy. So we've mentioned. Then over time, because of healing and repeated ulcers, they can get thickening and fibrosis of the skin. You can see here, these are very leathery like skin, and because of the iron deposit, they tend to become erythematous and itchy. But if you examine the toes, they do have normal capillary refill, which is an indication of vascular status. So the treatment is simple. Usually we use a graduated compression stocking. So the stockings will have higher pressure here and lower pressure up there. So there is a natural gradient for the fluid to flow back. Elevation is important. So reducing dependent position, prolonged standing. And surgery-wise, usually we strip the veins away where the valves are incompetent to treat the varicose vein. But venous ulcers can tend to be very long-standing and difficult to treat. Arterial ulcers, so people with arterial ulcers, as the name implies, have problems with the artery, simple. Yeah, so what affects arteries? Diabetes, it causes atherosclerosis, hypertension, hardening of the blood vessels, smoking, vascular disease such as vasculitis. So all this causes problem with flow into the area. And when you have impaired flow, areas that are more vulnerable are usually the pressure points. You know, when your ankle is against a hard surface and your circulation is poor, so these areas tend to get problems first, especially in the distal part of the circulation where the blood has problem flowing to the end, toes and the feet. So in this case, it's a lateral malleolar ulcer. You can see that there's this huge eschar. Again, these are related to the loss of circulation. And these tend to be punched out and deep because these are full thickness injuries. So if there's no blood supply from the base, the entire thickness of the skin dies. So it almost looks like a 4th-degree burn if you think about it. Yeah? So it's irregular in shape. So wherever there's circulation, there's growth. Wherever circulation stops, there's no growth. So presence of necrotic tissue, in this case the eschar, minimal exudates, tend to be very dry unless they get infected. Because of the loss of blood flow, the skin becomes thin, shiny, the hair no longer grows, the skin becomes cool, pale, there's weak or absent pulses, there is delayed capillary refill, and frequently they end up with gangrene because of the chronic poor flow. So treatment, revascularization. So what they do is they pass in a balloon, they can do an angioplasty to improve the flow. Antiplatelet medication is to avoid thrombosis, so they keep the blood flow growing even with a small lumen. And of course, risk factor management such as cigarette smoking cessation. Neuropathic ulcers are fairly common and fairly, they're typical in the sense that they tend to have this heaped up appearance, you know, and risk factors again, diabetes, trauma, prolonged pressure. These tend to be related to nerve, as we can imagine. Diabetes causes problems with peripheral nerve and they lack sensation. Trauma basically refers to the spine. So if there's trauma to the nerves, there's loss of sensation. All these pressure points tend to lose sensation, and they get the injury that tend to be on the pressure points on a dependent position. As you can see, the circulation tends to be quite intact. It is typically on the plantar area or the tips of the toe where there's pressure. Fifth and lateral metatarsal regions here, where the shoe wear could cause injury. Examination wise, you can see that they are tend to be deep. They're surrounded by calyces. They are insensate, you know, and usually the calyces are dry and cracked. So the treatment is basically, because you can't treat the nerve, so most of the time it's offloading. So offloading means we design a shoe where the pressure is distributed throughout the rest of the foot. Okay, so very quickly, pressure ulcers. Pressure ulcer is another huge topic. I don't want to go into too much detail, but basically, people develop pressure ulcers because of impaired mobility, poor nutrition, if they have problems with moisture. These are more for the perineal areas, the sacrum areas. So common locations, heel, and any bony prominence. So again, this one is a full thickness pressure injury. This one is a partial thickness. So can be deep. It is often macerated because of fluid. Again, the skin is atrophic. Most of the time, you see that the patient is debilitated. So they have loss of muscle, wastage of the calf muscles and the leg muscles. Again, treatment is offloading pressure, relief mattress, reduction of shear. I'll just very quickly, what you need to know is there are 4 stages of pressure injuries, stage 1 to stage 4. Very easy. Stage 1 is only erythema. Anything more than erythema is stage 2. Anything more than skin deep, when you see fat or muscle, stage 3. Once you see bone, 4. Yeah, let's go through that. So this is an example of an evolving pressure injury. So day 3, you see a bit of a discoloration on the skin. Day 7, it develops in a full eschar, you know, and then after that, when you divide, it develops into a 3rd-degree burns. Pathophysiology, risk factors. Basically, once the pressure of the area exceeds the normal capillary pressure, there's occlusion and tearing of the small blood vessels in the region, reduced perfusion, becomes ischemic, and then you get a pressure sore. So this is an example of how we avoid pressure sores. So very thick mattresses in surgery. Mattresses at all pressure points, even on the face. Factors that affect pressure ulcers, you have poor pressure, blood pressure, length of surgery, bleeding, even body temperature, but this is for surgery. Again, stage 1, I won't go into too much detail. It looks like this, just redness, no skin breakage. Stage 2 is when you see that there's already an ulcer. Anything that has an ulcer is at least stage 2. 3 is when you see underlying structure. And 4 is definitely when there's bone. This is automatically 4, so it's very easy to remember. To add to the problem, we have this thing called unknown depth. So for example, what we saw just now, so you cannot call this a first degree, so because basically there's full thickness loss, yeah. And there's also unknown depth. So the skin overlying might be intact, but the injury is deep. So the skin is intact, but injury is so these are sometimes what the nurses will use just to clarify that they are not sure about the depth. Okay, I think that's about there. Am I too fast? I've got a whole series of lecture on pressure ulcers, but I don't think I'll go there. Yeah, I know it's all these are readily available on the textbook. I don't feel that we should go into too much detail, but suffice it to say, venous pressures, venous ulcers and arterial ulcers are the most common. Venous being the most. Too fast? Catch nothing?
Does anyone have any questions? I got a thank you. Thank you so much for sharing. This was very interesting. That was interesting. Thank you. Thank you so far.
Thanks for having me today. And I know
so I've got sorry, Mr. Chu. So before people start leaving, I've got the feedback forms. Please fill them out. If we have slides from the lectures, we'll release them if we meet our target for the feedback form. So yeah, please fill them out so we know what your thoughts are, and this will impact all the other events we run. We like to know your thoughts, what's good, what's bad. Please fill them out, and we'll pass these on to our lecturers as well. This will motivate them to come back. So please fill them out. And if you've got any questions, we'll take them in the meantime. If you've got other career questions as well, or any specific questions for Prof Chu, please please do leave them, and you can unmute yourself as well to speak to Prof Chu.
Yeah. I see a question here about slides. I'm most happy to share the slides. So
okay, yeah.
Can reach out to Cleo, but they are a bit jumbled, and my slides are more for interactive kind of rather than the didactic kind of lecture. So may not be the best material to revise exams with. Yeah, just as a good to know. Right. So Cleo, if anyone has questions, feel free to just forward to me. Yeah.
Sure. I'm watching the chat now, and I'll let you know.
Okay. Sorry again for the length. I think I tried to strike a balance between the amount of depth I go into versus the coverage. Yeah. I'm not sure whether that's enough for your exams.
No, it's good.
Yeah, that was quite in depth. Thank you very much.
Very good.
Yeah.
Thank you.
If you can take like % out of it, I think that's probably enough for exams. Yeah. Thanks, Calvin and Cleo, for organizing this.
No problem, man. Thank you so much. Really.
Yeah. I'm sorry, it's a bit rushed because I just finished 3 free flaps in 3 days. Yeah. And then please apologize to everyone for not making it on Thursday, because my case was just a bit too complicated, and I guess I overestimated my abilities to finish in time.
I've got quite a few thank yous. Very interesting.
You're most welcome.
Yeah.
Most welcome. Yeah. So if there's any particular topic that you want me to cover, again, maybe bite size. I'm happy to spend half an hour clarify certain topics that might be confusing.
Yeah, I put all of these on the feedback form. So if anyone wants another session to cover specific topics, we can definitely arrange that.